everyone. Thank you for joining us today. This is Paul with VITA North America. We are very fortunate to have Mark Wagenseal with us today, talking about combination syndrome denture case, edentulous maxillary with lower dentition. So thank you all for joining us. Let me go through a little bit of housekeeping real quick. Sorry, 1 second. Get Mark connected here. Just so everybody knows, your phone will be on mute. We've got quite a few people today. So if you guys have questions, there is a question box in the panel on the side. Please type in your questions and myself and Mark will answer them as best we can. We will leave a little time at the end for Mark to answer some of those questions. So please type them into the little box. This workshop is recorded and we will send everybody a copy of this. If you don't get one, please feel free to email us and we'll be happy to send it to you. And we will also have a copy of it on our VITA Learning website. For CE, you guys will get CE. You guys should get that automatically. It should come to your email address. Again, if you don't see it, please feel free to email us and we will be happy to help you out with that. And if you guys have questions, please feel free to give us a call here at the help desk and we will be happy to help you out as best we can. Again, if you guys have questions, please type them into the box. And let's welcome Mark. Mark, I'm going to go ahead and turn it over to you and we'll get started.
Awesome. Thanks, Paul. Question number 1, can you hear me?
I can hear you great.
Yay. Question number 2, can you see me?
Our common single denture issues.
Excellent.
Thank you, Mark.
Sounds good. Perfect. Paul, keep a lazy ear on, okay? Because the questions actually don't pop up for me, so you'll have to read them to me.
No problem. I'll keep an eye on everything.
Awesome. All right. Hi, everybody. Good morning. Woot woot. Okay. Paul, can you see me?
I can see you.
Hi, everybody. Woot woot. Good morning. Happy day. Best wishes. Thanks for joining me. Thanks for investing in yourself. Thank you for trying to be a superhero for your patient, whether you deal with them directly or whether you're in the lab working for the doctor. They're still a patient at the end. So thank you for trying to be their superhero. They trust us. We do not slap teeth together. We do not do that. We are very technical. We do a very difficult job. So today we're going to be talking about single upper dentures to lower natural dentition. Those are fun. So I'm going to give you sort of my journey and my experiences. Gosh, I was just going to say, I'm 51. So I started caring for patients when I was 17. So it's been what, 34 years of my life now building dentures. And so it's the right path for me. I love what I do. I want to go through a few things with you first, a couple quick PowerPoint things. And then from there, we'll get into and I'll do some demo work for you. So thanks for joining me and thanks for investing in yourself. And this is about, again, trying to strive and trying to be that superhero for the patient, but more importantly, trying to control some of the common issues that we experience every day so that they become less issues every day. So we're going to talk about single denture issues. I'm going to stop sharing my webcam so now you can just see the whole PowerPoint. Okay. Okay, our common single denture issues. So what do we see? Denture teeth chip, break, and pop off. You can't chew well with a new denture. So the new upper tips, or they say that the new upper denture does not fit as good as the old one that they replaced. New denture, of course, then is more loose. Yourself or the doctor has relined it multiple times with no success, and the denture base breaks and fluid collects under the denture, but no reline warranted. So Paul, I have a quick question. Is everything popping up okay?
It
You can
looks
see
great.
you can see the PowerPoint.
I can see the PowerPoint.
Awesome, thank you. Just wanted to double check. Modern technology, but thanks for being quality control. Thanks, Paul. And Paul gets a woot woot this morning too. Awesome. And the new upper denture feels too big and soreness, so they come in for adjustments. And this is the big one, everyone. I just want to quickly verbally say this. The average denture wearer comes back to an office 2 to 5 times for an adjustment. So you can expect them back 2 to 5 times. So yourself or that doctor is going to be seeing that patient 2 to 5 times after the insertion. We don't usually charge for those appointments, or you give so many appointments included. You don't make any revenue during those appointments. Those appointments last anywhere from 20 to 30 minutes. You have to clean the room, get the patient in, find out what the issue is, deal with the issue, release the patient, chart it, clean the room. So you're looking at 20 to 30 minutes easy on an adjustment. So you have to keep in mind 2 to 5 adjustments, that's cutting into your time and that's cutting into your profit. So it's big. If we can control those things and control that aspect of denture construction, as well as our single denture issues, it becomes of great importance to you. These common issues cause us stress when we deal with them. You got to think about this. Day in, day out, day in, day out. I have adjustments come in, or the doctor's calling, or the lab slip, and you deal with similar problems, and they're repeat problems. It's not just from one doctor, but it's from several, from your entire workload, that you see repeated problems come back, and that you're always having to deal with them, take time out, and it causes you stress. You have to think about it repeated over days, weeks, months, years. It starts to wear on you after a while because you hear the same things, and that causes you the stress. And stress builds over time, and then that leads to burnout. So the first thing I want to address and start discussing with you and my dear profession that I love, and the profession of denture manufacturing and denture care, is that we have a stressful job with dentures. The patient has to eat with something they can't feel directly. There's no nerve into the denture. They can't feel it directly. So it's like walking on feet you can't feel. And so they're expected to chew and function with something that they can't feel. And so it's a burnout is real in our industry, and it's real. And as I lecture more and travel more and talk with you more, you realize that this is a prevalent in our industry and in our profession. In 2019, the World Health Organization has listed burnout as a disease, so it's now listed as a disease. Burnout is categorized as feelings of energy depletion or exhaustion, increased mental distance from one's job, feelings of negativism or cynicism. And so I want to just tune into the cynicism part a little bit, because as a direct healthcare provider, common for us is we'd say, the patient's crazy, or they're not realistic, or they're just old and grumpy. But we have that cynicism, or again, that doctor, and oh my gosh, as a lab, and that doctor, and he just doesn't know what he's doing. But we get cynical from it, because that is cynical from it building up over time. And then we also have reduced professional efficiency, disrupted sleep patterns. So if you're experiencing this, you can be experiencing burnout. A major sign of burnout, my dear colleagues, is if you go on a holiday, even a long weekend, and then you come back to work for a day or two and you feel like you've never had that holiday, you're dealing from burnout, and you're suffering from burnout. And that can be burnout from your job. So the one thing that I want to hone into is what I can control, and that's dentures, and that's denture manufacturing, and that's why I want to share with you my journey now. So the first thing is I want to talk quickly about freedom and centric. So those that have you heard me before, this will be a repeat, but a refresher. And that for those that are new, freedom in centric is something we don't talk about enough in our profession or deal with. It's a flat area in the central fossa upon which opposing cusps come into contact and permit a degree of freedom. So anywhere from 0.5 to 1 millimeter, and eccentric movements uninfluenced by a tooth incline, which means you can touch together in centric and wiggle side to side. And what that means then is before you start to be influenced by a tooth incline or the slope of the teeth. That's freedom in centric. So the real life example is holding your teeth together and holding it together. And now you hold in centric. And then what you're trying to do is you're trying to wiggle your teeth in centric. And what happens is when you do that, that's freedom. So then freedom is that little bit of wiggle room that we have. Freedom is good. So everybody say it loud and proud with me from wherever you are right now. Freedom is good. Most denture teeth on the market that we use do not incorporate freedom and centric. They have working and balancing occlusion, yes, but when you hold them together in centric contact, they are locked in. There's no freedom there. And so now, why is this important? And here's my beef, is that then the patient has to bullseye land centric every time. If they don't, then they touch on the guiding planes of the tooth and they slide into position. Whether it be an upper denture, a full upper and lower denture, implant retained denture, heck, natural teeth, it doesn't matter. You're asking someone to bullseye land centric every time. So you understand that this becomes difficult and impossible. I have my own natural teeth. There's a nerve into those natural teeth. My brain knows where my teeth are three-dimensionally, because every time I touch my teeth together to swallow, to eat, etc., my brain gets that reassuring pattern and feedback to say, yes, Mark, that's where your jaw is and that's where your teeth are. A senior citizen doesn't have that because now their teeth have been removed. They've lost that nerve. So the first thing is the central nervous system goes, well, wait a minute, where are those teeth? The second thing then is that, well, wait a minute, how do I know my teeth touch together? So I want to share this with you. I mean, when I first started, and I'd say to a patient, touch your teeth together. Well, Mark, how do you know they're touching their teeth together? And how can they feel that? And I just assumed they knew that their teeth were touching together and that they touched them together correctly. Well, then I kind of thought to myself, Mark, you big idiot, there's no nerve into those denture teeth. How can they tell? And then how can they do that accurately? And now we're asking a senior citizen who is aged, who has a depressed nervous system, or it's not as sharp, neuromuscularly, again, our system starts to decline with age. We have tremors. So now we're asking someone that has sort of decreased nerve capability to accurately close their mouth each and every time. So that becomes the problem. And then our denture teeth have been locked together. So VITA, lingoform, MFT posterior, and physiodens don't do that. They have a degree of freedom, which I'll show you. So what happens is when you hit and slide, the hit and slide into position becomes the problem. But remember, the patient can't tell you it's hit and sliding because they can't feel it hit and slide. It is not possible for a denture patient to close accurately and centric each and every time they shut their mouth. It's not possible. And yet we expect them to do it and we set it up for them to do it. So the problem lies is that it's the hit and slide. That's what causes the denture base to wiggle. That's what causes the sore spots because the denture base is moving and the denture base starts to do this to the gum, and you can hear me, and then that causes heat, and the heat causes the white blemish on the tissue. These are things now that cause the problem for us, is that that's what the wackling does, and then that's what's causing the, say, the locators on an implant to wear out in a month or two instead of lasting for a year. This is what's breaking dentures, or especially implant retained or permanently implant retained dentures, is we're expecting someone to pinpoint land a bite. And this is where we get confused because I have practitioners say to me, yeah, Mark, but my bite's right, and we're relying on centric. So that's where it becomes an issue. So I want to show you this video. This is an upper and lower, but this is freedom and centric. So you can see that it can wiggle a little bit in centric before you go in working and balancing. So I kind of tip things out of the way so you can really highlight and see this. So there's that little bit of wiggle. So it's about 1 millimeter in that centric pocket. It's like a helicopter pad to land in. And then of course, yes, the teeth will operate in classic working and balancing that we're used to, but it's that ability to wiggle side to side that we've forgotten about. And when I started to identify this, my adjustment rate plummeted. My professional happiness certainly went up because I'm not dealing with as much of the repetitive problems as I used to years ago. The other thing that influences how teeth operate is a chew cycle. So I'd like to show you this. This is just a quick video of some patients with natural teeth chewing. So pay attention to the chew. So here's some apple and watch the jaw. Is it moving straight up and down? Yet I've got practitioners, denturists, prosthodontists, doctors looking at me going, yeah, Mark, but my bite's right, my bite's right. Yeah, so they land in centric, but can they pinpoint land centric every time? And now when they're functioning, what do you see? The jaw's coming in at an angle and there's a pattern to it. It's like a teardrop. And when we set denture teeth, we don't think of this. That it has to come in and glide in uninterfered with no interference and then come into centric. It's not straight up and down. So I love watching this video because it's always a reminder of what this is going to look like in our patients when the denture is inserted. So you can see that there's an angle and that there's a teardrop to this. And the next video is most important because we've already shown you now 3 videos of a certain cycle. Now watch this patient and think to yourself, what do you see different? Can you see how it's more of a vertical cycle now instead of more oval? It's more up and down. That's the kicker, everyone, is that everyone has a different kind of chew cycle. And we don't talk about this and we don't educate ourselves on this. There's variances. Yes, Paul.
I got a couple people saying that they're not able to see the video.
Okay. I'm going back.
Okay.
Okay. So the video is running.
Video again, and for those of you who are on, put a comment in the question box if you guys cannot see the chewing video.
So it's running right now, Paul. Can you see it?
I can see it.
Okay. And it's running on my computer, so I can see it. Paul can see it. So
okay,
this is
looks like some people can and some people
can't.
That's interesting.
Don't we love technology, everyone? I'm surprised we can get out of bed in the morning sometimes. Look, I appreciate this and I apologize. I mean, if it's running from my computer and it's running on Paul's end, then I'm sorry. It could just be that the amount of data it's taking to download the video for you.
And this is where you slide the video on the right. If you're on a phone, there are 2 screens to choose from. So yeah, if you guys are on a phone, there may be more than 1 screen to choose from because we've got the picture screen of Mark and then we've got the video screen. So it looks like most everyone can see it. There's only a couple people that are having issues. Okay, it looks like we're all connected now. I'm getting some positive feedback. So let's go ahead and continue there, Mark.
Okay, thanks everyone. When those things pop up, yes, type them in and Paul's keeping an eye on it for us, okay? Because I can't see the chats that come through, even though I click on the chat box. And I think that's just because VITA is sort of the running things because I can't see it. Okay, so thank you for that. So we have different kinds of chew cycles. And so then that influences how the teeth work. So now what happens is you have a chew cycle and the cusps have to function within that chew cycle. And if they don't, that's what's causing the hit and slide. So we pay all of this attention to how it works on the articulator, but not in the patient's mouth of how it really functions. A patient has a chew cycle like I have a fingerprint and a retinal scan. I have a chew cycle. It's unique to me. And now the brilliance of this is identifying that so you can see it. So then you can control the hit and slide. which are their little red marks. The hit and slide causes the problem. Remember, I don't have a nerve into the denture teeth, so I can't tell you it's hitting and sliding. And boy, when you look at it on a patient, very difficult to see it visually as well. But what are they feeling? They're feeling the wiggle, the shake, it's loose, the sores. All of our common issues are tagged and related to the hit and slide. So let's talk a little bit about some tips about how to identify chew cycle. So this patient is going to say 66, and instead of looking at the aesthetics and the positioning of the teeth that we're taught to in a wax try-in, let's look at how the jaw is moving and the function. Boy, did you see it at the end? How the lower jaw postures out to the left and comes forward, and actually the lower anterior teeth exceeded the upper anterior teeth. We don't check for that. What I'm looking for typically, and what school taught me, is I'm looking at all the aesthetics. But you have to remember now, certain words produce phonetics. So the A, E, I, O, U, the phonetic combinations of our language, whether it's in English or any language, the phonetics of that language are always found in the days of the week and the months of the year. And now I've been experimenting, and even with words like 66 or counting from 60 to 70, you can see the jaw posture. So what did this tell me? This tells me is that her lower mandible swings out to her left. So the chances of the posterior teeth hitting and sliding into position. So I need to now pay attention that she has more freedom out to her left, which means I need to set and sculpt the denture teeth to be able to handle a drift out to the left. So I'm setting this now in the PowerPoint so I can show you this once we do the live demo. This lady. You see her jaw move? Look at that sucker. So this is how she speaks and talks. So now I need to give her clearance with her teeth. And I need to make sure that the guiding planes have clearance, so there's no hit and slide. Now, when you see her speak, you can see that there's lower anterior teeth. You can see things aesthetically from a aesthetical perspective. But again, I want to draw your eye to the function of the language. And you can start to see it with the mandible. Look at that. So now what did I build for her? Well, look what I built. I built an upper and lower, and I buried the lower occlusion. It's, what is that, 5 or 6 millimeters of overbite. This thing should never work. She wears this without adhesive because I gave her clearance. I gave her the ability to move. I identified her jaw tracking, and then I could set the teeth within that function limit to function, and clearing it more on the left side, her left side, so that, because that's where I know she postures to. So another quick example of 66, I colored this lady's lower natural dentition with ink so you can see it. She's in her mid-20s. And as one of my courses once, look at her jaw move. See, it comes forward and then it's posturing. So that's what we're checking. So when you can start to look past the aesthetics, it's going to help you with the function. This is a video sent to me, so props to Campbell Dentistry in Iowa. This is a upper complete denture and a lower cast frame partial, lower natural anterior teeth. So watch this patient chew. You see a chew cycle? Look at that. There's the chew cycle. Look at that. So that's a denture patient. the chew cycle doesn't go away. It's always there. Denture or no denture. So now the trick is you have to set denture teeth to function within that chew cycle, everyone. So this is a combination case. So this brings us to why we're here today. So a chew cycle influences tooth interaction. You have to modify teeth, traditional or digital. If you do a digital application, it doesn't matter. So now, how am I going to start to do that? So I want to run this video. So this is me, and I use a Protar. So typically what we do is we use this. So we do this with an articulator, okay? And those are the sort of typical movements that we use, okay? And I'm going to show you in time how I want you to move the articulator, okay? So now this is a close-up of those teeth. So now, from a standard position, what I want you to do now is start to move the articulator like a chew cycle, like the teeth are really chewing. Because now that's going to help us identify the hit and slide aspects. The issue lies is that you need to identify what kind of chew cycle the patient has. So you need to see this person, you need a video, or at the very least, you can make an educated decision. So what's an educated decision? Well, you'll know if you have the age of the patient, the older they are, the less reactive and the less accurate the central nervous system is going to be, and the sloppier their chew cycle is going to be. Okay, so that's an educated guess. If the upper denture that you're replacing is really worn down and you have a copy of it and it's really worn flat, then again, it's worn flat. They're going to have a very ovoid or very horizontal chew cycle because they've been having to mill the food to make it work. So then you know that that's what it's going to be like in the mouth. You can make some educated guesses. Now this slide's very important because this kind of is the backbone to a lot of what I do and preach. You do not chew in centric, everyone. Yeah, Mark, my bite's right, my bite's right. You don't chew in centric. That's where we forgot. That's what we've forgotten to teach in schools. This is what we forgot when we get out into private practice. And this is what we've forgotten on the lab bench. And I mean this respectfully. And this is what I forgot. And then I slowly started to realize, what am I missing here? I have these complaints coming to me all the time. My bite's right. I remounted it. I did all these things that school told me to do, yet the patient is still complaining. What am I missing? So my OCD took over and I started to think, well, okay, what am I missing? And so here I am today, 34 years later, trying to share my journey with you because I would like to leave a profession better than when I got into it. And I want to lift us up and make us better and help patients that put their trust in us. We don't chew in centric, everyone, but it has to function in a chew cycle. So myself and Vita want to further our relationship with you and ergo that patient that places their trust in you. You can be that superhero. These are the representatives for Canada and the United States, and I appreciate VITA North America's kind support and support of me to deliver my message to you. And so these, again, are the sales reps. So this is a recorded session, so you can always pause the recording after and then get a hold of your sales rep. Here's the thing, VITA teeth have freedom and centric. So that's the first importance. And that's what's going to carry us through now when we switch over to the demo. And so now I'm going to click out. So if you give me a minute, I need to get to the camera. Whoops. Okay. All right, Paul, I'm just going to make sure that you can see the camera now and my hand.
I can, you're looking good.
And me when I rotate myself. Hi, everybody.
There you are.
All right, now what have we learned? Freedom is good. And now there's a chew cycle. And now you can even watch me and look at my mouth move. And this is the beauty of a live course. Hopefully next year we can get together and please ask VITA for live courses so that I can sit with you and we can look at chew cycles. Heck, because in live seminars, I can get everyone together and we look at our own mouths, and you can start to catch and see the jaw move, the positions of the jaw, and then how you're going to set teeth into it. So again, my eye was trained initially to look for aesthetics, and now my eye, I've retrained to look at a function. So when I see Paul maybe next year in Chicago and he's chatting with me, I'm going to be looking at your mouth, Paul, and I'm going to be checking you out automatically to see how your jaw's moving. That's what I'm asking, is you have to retrain your eye, and it's hard to do. It's been my journey for how many years now, but it's been beneficial for me. So remember, we have wiggle. So we have freedom. Freedom is good. So we have a little bit of wiggle. Our bites aren't locked together. And now we have a chew cycle. So I'm going to rotate. We're coming down now. And I have different kinds of models and articulators. So we're going to have some fun. And I appreciate that this is on a, I appreciate that this is digital and we're doing this on a computer and it's a webinar. And I mean, gosh, it'll be nice that we can do this in person. So you can see now that we have a very, very sort of flat occlusion. Okay. And there, that's the money shot I wanted to show you, right? Things are really kind of flat. So you have to appreciate when I'm tipping this and looking at the screen, I got to tip it in the opposite direction of what I really need it. So everything's reversed here. So, okay, so we're going to start to set teeth, and I'm going to show you this. So I have several different kinds of models here that I have just kind of taken out of production, and they're all varying degrees of natural occlusion and cusps and no cusps and teeth and flat teeth and everything like that. So to appreciate that everyone in every situation that you're going to find as you move forward doing this is a little different, but we can discuss and show as much as we can. I always like these. It kind of shows us these models here that, now let me flip the image. Okay. Oops. There we go. When it flips. So remember, this patient is chewing. So whether this is a natural tooth or a denture tooth, it's chewing. And then the issue lies is that we got to watch the guiding planes, these suckers here, okay? Because this is where the hit and slide comes in, and then that's what's going to tip the plate and rock it. So we got to watch that motion, okay? That's the killer. And once you can start to identify this is really good. Because remember, oh yeah, Mark, my bite's right, my bite's right. You don't chew in centric. The minute they start to open and chew, there's a cycle, and then it's going to hit and slide. And I did my job right, because on the articulator, I checked for working and balance, and I did everything right. Yeah, well, what happens on the articulator is not the chew cycle of an actual individual. And I had to get out of my own way. And I mean that sincerely. I had to rethink how I build dentures and how I do it, how I analyze and look at a patient. What do I do? So you can already start to see I've retrained my eye on, instead of looking at aesthetics, I've retrained my eye to look at function. And as a dental technician, for all of you that are listening, I appreciate that's hard, because how do I get my doctor to do this? Well, phone calls and training, or at least ask them to send you a video of the patient saying the days of the week and the months of the year in English and their mother language. Because remember, days of the week and months of the year activate the phonetics, and the phonetics activates the jaw and moves the jaw. So that's what we want to do is get the patient talking, because then that can kind of help us. So I'd like to point out that look at me work today, everyone. Huh? Fantastic, hey? All right. So forgive me, I'm going to try to not. Okay. All right. So I'm going to remember to hit focus a lot, and we're going to start to set on this side, and I'm going to set the posterior teeth. So I'm going to bring us in a little bit again to really show you kind of what we're dealing with. Let me turn the light back on. Maybe that's too much light. Yeah. It's kind of better without, but you know, you can come in and just see these molars, right? Like it's pretty flat. Okay. So I'm going to tuck in here and go in real close. So forgive me, I'm going to just play with this a little bit just to check lighting and focusing. Okay. Let me just center that a little bit. Thank you. Okay. So number one, I am trying to find the center of the tooth where it's basically the deepest part. So on this tooth, you can kind of see it's right in that area there. It's fairly easy to see. This one, it's right about in here. So if I do a little bit of a tip to it, you can again see. So it's right in there. What I'm trying to do is find the bowl, okay? So what do I mean by the bowl? I'm trying to find sort of if there is, sort of the deepest part of the tooth. So if I draw this for you, I'm trying to, and I'll over exaggerate the picture, but I'm trying to find this area here, the deepest. So yes, things might be flat, but maybe there's a little divot or something. I'm trying to find the deepest part, okay? Because then what I'm going to do is I'm going to start to try and rest my upper lingual cusp within that and start to customize it within that, okay? So a couple things about VITA teeth, lingual especially. So lingual ta-da. So these are made from acrylic glass. This is acrylic glass. I can grind this and I don't have to polish it. It self-polishes. I know, how cool is that? So it's 85% polymethyl methacrylate, 14% silica, which is by definition quartz, which is by definition glass, and 1% shade. So the idea behind this is I want to take this lingual cusp that I circled just in red, and I want to drop it into that spot there and then start from there. So what do I do? Well, we're all going to go reach for our handy dandy articulating paper, okay, of different kinds, shapes, thicknesses. Yeah, we all have articulating paper. Don't use this. Articulating paper bends. I've really stopped using articulating paper. Now you're going to say, what, Mark? You crazy coyote? What are you doing? Well, this is what I'm going to show you. So bear with me. So I'm going to zoom out for a quick moment and I'm going to do this. Okay. And let me try to get everything centered. Thank you for your patience. Remember we used to do that, right? And I showed you the video of that's how we normally do an articulator movement. So one side stays locked and then we open this, and it doesn't matter whether you use a hinge articulator, I don't care. They all do this of some way, shape, or form. And I'm telling you to stop doing that. I don't do that anymore. I take my articulator and I do a chew cycle. What do I think the patient chews? and I'm using the articulator to help me within its limitations and design to give me a chew cycle. And I can do this on a hinge articulator. It doesn't matter. You can make it work. You just have to hold it differently. Okay? So I've retooled how I hold an articulator and how I manipulate that articulator. Because now in those videos that I just showed you of people eating, did anyone do anything that resembled this movement of how we check? Huh? Did anybody do that? Any of those videos? No, because that's not how it's represented in the mouth when you eat something. You eat in a teardrop. So then why aren't we doing that on the lab bench? We got to get and start. Don't do that anymore. Start to manipulate your articulator and do like a chew cycle. That's the first thing you can do in the lab, whether you're a denturist, prosthodontist, dental technician. When you start setting the teeth, you can go in and start moving the articulator differently. Okay, be more reflective of how it's going to function in the mouth. So what I'm going to do is I'm going to take the tooth, and you can see how I've colored the top of the tooth, or the cusp tip. So let me do that again. So we're going to do this cusp tip, and then I start to line things up of where I want it to go. Okay, so bear with me while I retool everything and get the wax in a favorable spot. Okay. So when I did these demo models, I made sure that I had a lot of room, so we didn't have to do much grinding of the basal part of the tooth. So there you go. So we're going to kind of start to line things up in and around that position. Okay, because that's going to be, as I said, kind of centered of where I want. Now here's what I do is I come in and I gently tap that in. And then what's going to happen is that red mark will start to show itself here on the tooth. So then that'll start to show itself here. So this cusp tip will start to show itself here. So what I'm going to do now is, because this wax is soft, I'm going to take this tooth off. And now what I'm going to do is I'm going to start to grind the cusp tip and start to shape it so it fits into the lower counterpart. So I'm going to start to take this and modify this cusp tip to start to fit in here as my centric contact point. Okay, so that's order number one, or job one for me, is to do that. Okay, so forgive me. Now you're all asking, what am I using to grind? So you can use a rubber wheel or a real fine burr. Okay, so a rubber wheel or something really, really fine, because then you don't have to polish this after, it's going to self-polish. That's really a selling feature for me and the VITA teeth. So now I'm going to take this again and I'm going to color it. Just so that we know, I'm using a Staedtler non-permanent Luma color. So it's non-permanent, Staedtler, made in Germany. You can also use a Sharpie, but just again, make sure that it's non-permanent, okay? And then I'm going to come in there and I'm going to gently tap into position. Now, the reason why I don't use articulating paper is articulating paper can bend. And then what happens is you get a wrong or erroneous reading. So what I want is I just want an actual, where's this thing fitting? And then the beauty of this is as it wears, it'll actually mark it on the tooth even, and it'll wear out the spots so you'll actually know where the contact is. So it's really finite work. So I've stopped using this because this will bend and give you erroneous readings if you're not careful, but then it's also thick. So now I'm just going from tooth to tooth without something in the middle. So it's more accurate. And then what I'm doing is I'm custom tapping it in to centric to get my contact point. So I'm going to take this off and I'm going to touch it up again. So I want to share this with you guys. As a denturist and a direct provider, so my fingers go inside someone's mouth and I make key decisions for that patient, whether or not I'm going to open the vertical or not, and build the teeth. My most precious talent is number one, the patient care in the chair. So directly touching the patient and making key critical decisions. The second most important talent I have is the setup, how I set the teeth for that patient. So for all of those that share that with me, that can see the patient and also set the teeth, those are your two biggest attributes and sort of key features that you have is your decisions that you make in the treatment room and how you do your setup. As a dental technician, your most important person, so to speak, is the person setting the teeth, not the person waxing or flasking or such. How those teeth get set is key because that's how it's going to function in the mouth after the fact. What's important is we slow down and we think about what we're doing and we take our time here because what we do here is going to affect how the sucker operates in the mouth after the fact. I appreciate we're busy. I appreciate we have quotas. I appreciate I have patients wanting me and time. But what's important is that I spend the time here to make sure that I line things up properly. Because what I'm doing is I'm setting the centric tone for this. So now I can go in centric, but now I'll take the pin out of the articulator. And what's important now is this motion. How is this tooth functioning against the lower natural within the perceived chew cycle of the patient? Because now that tooth has to operate within that chew cycle. So let's talk a little bit as I switch back to this model. Okay, so the patient chews. So here's some key points. Number one, this right here. We want to keep this overlap and we want to keep it overlapping the bottom buccal. So the upper buccal overlaps the bottom buccal. Sorry, I think I hit mute there. We want to do this because this helps keep the food up onto the food table to get chewed. So the lower is the bowl. You heard me use that expression before. The lower is the bowl. Its job is to bring the food up to the upper cusps to get smushed and crushed. So this lingual cusp here is designed to crush the food within the bowl or the confines of the lower. So we want this cusp overhanging to act as a shearing cusp to help keep the food up on the bowl. The lingual as well. So the buccal upper, lingual lower are there to help keep food on the food table and shearing cusps. Now, for all of those 20-degree setup guys out there, Remember, buccal upper, lingual lower means that's where you're supposed to have contact according to the setup principles of 20-degree teeth. And I'm here to say, no, don't do that. Not with VITA teeth. You don't want that. You don't want any contact buccal upper, lingual lower. So when I switch back to this and turn the light back on, and let me try to just orientate this a little bit for you so you can see it, you're going to see that I want this overlap. Okay, I want that overlap. I want that overlap to help keep the food on this lower tooth. This lower tooth, regardless of its shape, its job is to take food and bring it to the upper here to get crushed. So again, the buccal cusp overlaps the lower. So that's what I'm trying to do. I'm trying to overlap, because before, in the good old days at the beginning part of my career, I would take articulating paper, I would lay it down, I'd tap this, I'd get out a big burr, and I'd just grind the living heck out of the tooth till everything touches together and I've got contact. And then I'd pat myself on the back and say, good, I'm done. And then I'd send it out and I'd wax it up and finish the thing. And now I'm not doing that. I don't want tight contact. And you're asking yourself, but why, Mark? Why? Before, we're taught tight contact. You just hammer the thing down till the upper denture tooth rests against the lower in whatever shape you can. Okay? If you've got tight to tight, so I'm like this, where does the food go when the teeth come together? If there's no gap in there, where does the food go? How's it getting crushed? The food then gets pushed off the teeth. It's less efficient. You want gapping in here. You want some gapping so the food can stay on the teeth. So going back to the video, when someone's chewing carrot or an apple, the food was staying on the lower because, again, there's slight gaps there in the non-centric position, so slight gaps where the food can stay on to get crushed. So when I stopped knuckle tighting it, so again, we were taught to have this knuckle tight occlusion, and it has to be tight. No, it doesn't. Stop. Because what I realized is when it's knuckle tight, there's nowhere for the food to go. So it goes off and it takes you twice as long to chew, so to speak. Number one, that's a problem. Number two, when there's that much contact, there's going to be a hit and slide because there's so much of the tooth contacting and the patient can't feel. So when they're trying to come together, there's the hit and slide. And remember, the hit and slide causes all of our grief. So when I started to open it up and have gaps, have the buccal overlap the lower, customize the upper lingual cusp into whatever this shape is of the bottom, and do as much as I can. So even though this cusp might get very flat, there's still that crusher. There's still that crusher on the lower. The upper's overlapping the lower, so the buccal overlaps. It helps keep the food on, and then I'm more efficient. And then I'm operating within a chew cycle. And then I can check to make sure that it's not hitting on the guiding planes. So then I would make sure that these guiding planes here that I'm now coloring in green using my Stadler non-permanent made in Germany pen, that I would go and I would follow the chew cycle. And then I'm making sure, you can see there's a green mark right there. And then that means that I had a contact. So then I can go in, and the beauty of these pens, you can just see it on the video. Look at that. You see where it's missing? There's that little white spot right there. That's where it got rubbed off. And then I know I can just touch that area right there with a burr to, again, facilitate my chew cycle without interference. So again, the older the person is, typically what I'm seeing is the more horizontal that chew cycle is going to be. They're not as accurate. And again, if they have a really worn down denture, this thing's going to be more horizontal. But I'm watching them aesthetically using aesthetic cues. So again, the days of the week, months of the year in English and your mother language. And then I'm watching their jaw posture from the pronunciation of the phonetic words in the English language or their mother language. And then I can start to adapt. So if I knew this person was always going to swing out to their left, so that's why I'm moving the articulator to my left. So as I know if they're swinging out there, then I can go in and grind even more away from the guiding planes. So when I said to you,
Mark,
yes, Paul.
we have a quick question in here
Yeah, shoot.
that asks, aren't we effectively lingualizing the occlusion when you're setting the teeth?
Okay, so the answer to that question is effectively yes. I am doing a form of lingualized occlusion customized to the lower of that patient within a chew cycle. Yes, I am. And the reason why I'm going to say yes is because everything that I do in my office is a variation of lingualized occlusion now. Everything. And I use lingoform on everything because I can adapt this tooth to my needs. So I have a very small tooth stock because this is what I use. And then I adapt it to all the cases. I don't have 0 degree, 10 degree, 20, 30. No, not anymore. I have totally, I don't care what the degree of the teeth are anymore. I don't use 20-degree teeth because you don't chew in 20 degrees. You chew in a chew cycle. And now I'm modifying this to that patient's chew cycle. So yes, to that person that asked that question, this is a modified lingualized occlusion. Yes, 100%. I'm just not taking the upper and grinding it to just fit right tight flush down anymore. No, I am strategically lingualizing this thing. Yes, 100%. Guess what? You get a woot woot for that one. Woot woot. Great question. Paul, does that answer the question?
Yeah, it looks like it. Thank you.
Good. Thanks, Paul. Paul's the supervisor. Thanks, Paul. Okay. So now I'm going to do the second molar. So I'm going to bring it in. I'm going to color the lingual cusps. And then I'm going to come down. I don't have to lock the articulator. That always helps. And then I'm going to start to touch. So granted, maybe this isn't in the ideal place. I'm just wanted to use this as a demo because again, the tooth's going to go where the tooth's going to go. So let's just pretend. And you see how I'm going to tap it down and then it's starting to mark here on the lower. So let me take that off. So it's starting to mark and then you can see that tooth has got a fairly flat profile, but I'm shooting for right in there. And then you can actually see right there some of the contact right on that cusp. And then I'm going to go in and I'm going to grind this tooth to start facilitating a better contact. So instead of a sort of a pinpoint contact, I don't want that. I'm trying to get it, a stronger contact point in centric.
Mark,
But then at this, yes, Paul.
one more question.
Yeah, shoot.
When you just have one tooth in place and checking tooth contact without a custom incisal table, there has to be contact on the tooth because it is the only contact spot. Why not several teeth prior to checking lateral movement contact?
Right. Okay, so this is for demo purposes today that I broke it down tooth by tooth to show you how I set it. You're correct that once the whole setup is done, then you can check this chew cycle movement. Yes, and you can do it at that stage. So I'm kind of lumping everything together and doing the whole thing per tooth. But yes, to answer that question specifically, I would set each tooth in centric contact on its own. Once the setup is finished, I'm going to go through then at that point and do a chew cycle and do any modifications on the guiding planes then. Typically, yes. Okay. Now, sometimes I will fiddle a little bit because you can see the width of this tooth and the width of this tooth are quite, there's quite a discrepancy and disparity between them. So I have to keep in mind that I've got the pterygoid muscles starting to come back here. And it's quite possible this might have to go into crossbite because I don't have as much space up here. So that's when I might start to do a lateral movement even sooner in terms of just referencing where I think, and once I lock the articulator, where I think this distal buccal cusp is going to be, and will it start to chew the cheek? So I got to be careful. So in some cases, I remember that because I've seen the patient and I've done an intraoral exam and I kind of know what my limitations are back there in terms of muscle thickness and such. Because I always go back here and I poke with my finger to see how strong this pterygoid muscle is back here. Because remember, you have a lateral pterygoid and a medial pterygoid. So you have one that runs up and down and one that runs sideways. And so in some cases, when I do the setup, I am going to check already for lateral excursions before everything else is finished. So look, it comes down to, in all reality, just because I do it this way, doesn't mean that you have to do it this way. This is just me showing you on a demo perspective today. But to that person that asked that question, yeah, you can set everything up in centric first, following sort of the principles that I'm showing you, and then check for lateral excursions. Sometimes I do it that way, and sometimes I'm checking while I'm going, just because then I might need to move the center contact over, and then I'm going to change that. So then that's why I'm doing a lateral check as well on some situations. So it can be either or. Okay, Paul, does that think we answered the question on that one?
Yeah, I think so. It sounds good.
Awesome. Okay. No, I appreciate that. Keep interrupting as we go. So again, that really, again, that question, thank you, already spurred a bunch of my next topics about coming in here and the pterygoid muscle, and then now we're running even into a crossbite consideration back here, whereas the buccal isn't, but the mesiobuccal isn't crossbite, but now the distal buccal, we can start to tip the tooth and start to get into a crossbite. And again, it's the same motion from the perspective of a chew cycle when I color this in green, because now this buccal, mesiobuccal, is not in crossbite, but this distal I just set in crossbite. Okay. And then I would go in with a chew cycle. And again, I'm looking for the green marks that you would see here coming up the very slight guiding plane of that tooth. So then I can go in here and you can see the mark right there. It shows itself. So that's why I like using the pens, everybody. I've really gotten away from using articulating paper in the lab. I've gone to the pen usage and it's been good. And that's why it's given me very finite, detailed work. And that's how I'm sort of coming through here now in terms of this setup and function. So sometimes you have to go crossbite, sometimes you don't. You have to be careful back here because of the pterygoid muscle, and it gets really tight. So, and that is again the disparity because of this is much narrower than this one. So the first molar here is a crown. This is much narrower. And then the second molar is a lot thicker. So you can see that disparity then from here. This is a little bit more all in terms of width, it's a little bit more similar. So now I have to be careful because again, I'm really concerned about nipping back here. So if you don't know and you're the dental technician, and I would always err on the side of caution, that I would say then since I don't have information about this patient, I am going to take this tooth and throw it into crossbite just to create a little bit more space. So the reality of it is, why do you make those decisions when you don't see the patient? And why does that matter? Because the decisions you make right here, everyone, when you set these teeth up on the bench, it affects how it functions in that patient once it's inserted. So you bag it up and you ship it to your doctor, and the doctor puts it in. The reason why you made those decisions is you're trying to save him an adjustment. You're trying to save him non-revenue work, because an adjustment he can't charge for. The minute you start charging a patient for an adjustment, they will stop coming. Okay. And then are they more likely to refer work to you or to that office? No, because they're not happy. They've stopped coming because you've used the money as a barrier for them to come in. So if they come in, now you're doing work for free. So you do 4 adjustments at 30 minutes. Okay, that's 2 hours you just did for free. Okay, you guys, 2 hours of work that doctor had to do for free. If you can save them some trouble and do the work here, then what's going to happen is he thinks he's doing his job right. So he's happy, but then he's happy with his lab because, hey, they're not causing me trouble. Everything seems to fit great. And then he talks to his colleagues that send you more work. See where I'm going with this? Because the patient's happy, the doctor's happy, and then they keep sending work to you, the lab. The flip side of it as a denturist is I'm also trying to then manage my stress and my time. When I don't have to ping the patient back, they're happier. Oh, geez, yeah, Mark built me teeth that fit. They refer patients. And that's the best form of advertising. Yes, Paul.
Sorry to interrupt.
No, please do.
Another question. How often, if ever, will you drop a tooth on the lower arch when doing a class 2 setup? And if you do, is it the 5s or the 7s?
I will always drop a premolar, the 5s. Yes, because I want a larger molar because it has a larger surface area to bring the food up to get crushed. So I will always try to keep a first molar and a second molar over premolars. Absolutely. Because it's a bigger table to bring the food up to get crushed. Because I want less chews. Okay? Because again, they're trying to function with an artificial appliance they can't really feel. So I want to make it as efficient as possible. Okay?
Perfect. Thanks, Mark.
Awesome. Thanks, Paul. Keep interrupting and keep sending those questions, you guys, because this is how we share and this is how we grow. So it's fine. We're in a good environment here to do that. So that's why you make the decisions here, because you're trying to save yourself the grief there. So I'm trying to save myself the problem there, or my doctor the problem there. Then the other thing you do is you have the manager or in a lab environment, you have the denture, say the denture department manager call say the top 5 customers or doctors that you do dentures for, and you track this stuff. So you change and you start to implement what I'm teaching you today, and then you follow it. And you say, okay, so you call the dental office and you say, okay, hi, Susan, we have patient Smith and Miller and Johnson. How many adjustments have they come in for in the last 2 months since we built those dentures? And she's going to total it up for you, and then you can see, and then you can go to that doctor and say, hey, we've dropped your adjustment rate. This is why, because we've done these changes in the lab. We're trying to be more efficient for you. Because once you educate someone, and especially once I educate, for example, and I'll pick on me, once I educate and say to a denturist or prosthodontist, how many adjustments are you doing a month? And if you can cut that in half, do I have your attention? Boy, do I have your attention? Because you guys, how many adjustments does a denture practitioner do? Well, I've traveled enough now around the world. I've got a pretty good idea, depending on how busy your practice is. But on average, you're going to do anywhere from 20 to about 150 adjustments. Now, that's a wide swath, but just put the number aside for a minute. Say you're a slow practice, but that's because that's how you want it. But if I can take that 20 adjustments and cut it to 10 at 30 minutes an adjustment, how much time have I just saved you? Or you've gone from 150 adjustments to 70 in a busy practice. You guys, that's a big deal. And once you identify that and can acknowledge it, it's important, because it's about creating efficiencies, and it's about reducing your stress
Mark,
and your burnout. Yes,
another
Paul.
question, Mark.
Yep.
Do you use canine guidance, or do you keep them from interfering with the occlusion?
Oh, great question. Okay, I switched models. So now I've gone to this. So this is common, hey, where we've got this hodgepodge of, geez, look at that plane of occlusion, right? It's all over the place. So remember now that patient that I built that denture for, that I buried the thing down here. I thought, let's try this. And then I just made it sure that I worked within her chew cycle limit, and the denture worked just fine. So here's the thing about canine guidance. So to answer that question, typically speaking, I am going to set all those teeth up, and then I'm going to do a chew cycle movement. I'm going to come through and do a chew cycle. My goal is to not have things touch and hit within the limits of that chew cycle. If I go far enough, then yes, it'll hit. I'm trying to not. So I don't so much worry about an incisal table anymore. And that's controversial comment, but I really don't use one anymore. I'm more worried about the chew cycle and how the teeth are functioning within that chew cycle. So to answer your question specifically, I'm not so much worried about canine guidance. I'm more worried about how those teeth function within that perceived chew cycle of that patient. And if I make a mistake, then I need to widen the cycle, which means then I'm grinding the guiding plane some more, and I'm trying to get rid of that canine guidance. Because again, typically on a denture, we are not going to have canine guidance and let the thing ride up. It's not going to function like that in the mouth, like we would have on natural teeth. Because remember, the one thing that we keep forgetting about is there's no nerve, they can't touch. Excuse me, they can't feel when they touch. Okay? Paul?
That sounds good.
Okay, if they have a response back, let's let me know. Because
Okay.
that was also another, we have some really awesome questions today, guys, so thank you. Okay, so I switched that bottom out, and then I'm just gonna sort of retool myself here just to show you now a different scenario, because we did a lot on that other model. So, you know, here's the kicker, right? I have a tooth, and the goal is that this tooth is to bring the food up to get crushed. The trouble is look how it's leaning. So would you say that gravity is going to push this food and let it slide forward? Well, it could, because the tooth has got such a cant to it. So how do I start to make this work? And so again, we're going to get a tooth in here. So let me just get it organized for you. I'm going to back off the camera. I need way more wax, everybody. Okay, so it's snowing in Edmonton, Alberta, Canada today. So that's where I'm located. And it's 22 degrees below freezing. Is anyone feeling sorry for us yet up here in the cold north? Okay, so again, you're gonna see me kind of come in here. Okay, so here's the thing. What have I learned? And again, allow me to I gotta kind of do this in steps. When I first started, I would have tipped that tooth to really match the angulation of the lower. So I would have taken this and tipped it, you see? And now I don't do that anymore. I try to keep this straight, and then I'm gonna custom come in. So I'll be grinding a little bit more internally on this, but I'm keeping the tooth level. What's it doing is it's watching I'm watching the plane, the occlusal plane. I'm keeping my overlap, but I'm trying to let the tooth sit level versus tipped. So it's the same protocol that I'll come in and I color the cusp tip. And then I'm going to come in on a tap. And then you can see where it's going to start to mark here. It's marking on the lower. You can just see them, right? So it's nice because it's just finite. And then I'm going to start to grind this in. So I'm going to be taking this cusp, specifically the mesiodistal cusp. And then I'm going to start to so I'll be grinding more, and I'm just going to use the green, but I'm going to be grinding this more. Okay, sorry. Let me get that better for you to see. So I'll be kind of grinding in that area there. So I colored that in green. And then that's going to be resting in and around this area of the tooth here. Okay. So I'm holding this at an angle, guys, because of the document cameras in the way. So I can't always hold it straight. But the idea is to try and keep the tooth more level and not have it arc here. So I'm trying to, again, have the upper, not have the teeth tipped. I want the pressure going up and more straight for stability. Because I noticed that in my career where I'd be setting teeth and then the patient would comment that the denture feels like it's thrusting forward. And for the life of me, I thought what the problem was is because, again, my centric was right and I was happy with my bite was right. But what was happening is because the teeth were tipped, because the lowers were tipped, everything was getting pushed forward. So even though on centric, there was a shift forward because the teeth were tipped. So when I can try to keep the upper this way, I'm trying to angulate that force on the upper to go this way instead of this way. So it was a rethink for me. So in 34 years, I've been busy thinking, everyone. So again, you can see that I'm going to have overlap there. So again, I want those cusps overlapping to help keep the food there. And then again, I am always coming in and coloring and coming in centric to again facilitate my centric position of that tooth. And then from there, follow through, on a chew cycle. And I'll flip the view here. On a chew cycle, and again, then watching the cusps. Okay, and then I always color them in green. So my freedom cusps are in green. I call them a freedom cusp because I don't want that hit and slide contact. So then that's free and clear in here. Okay, so on these different types of situations, so now if I took anterior teeth, so let me get some more wax here. And we'll kind of do a little bit of a follow-up to that question about the canine guidance. Okay, so there we go. I'll center everything back so you can see it. Thank you. So I'm going to jump just to some anterior teeth quickly here, okay? So, and specifically say, let's talk about the canines. So let's get a canine in place here. Okay. Okay, so look, I'll just drop the canine here for education purposes, okay? So again, what I'm not trying to do is open the articulator and then come and see, is there canine guidance or canine rise? Now, in this case, it's obvious that there will be because I've got it really buried down in there. But I'm trying to not do this on the articulator with that movement this way, okay? Remember, I'm gonna open it up and I'm gonna do a chew cycle movement. Now remember, yes, Paul,
Another question.
shoot.
Is canine guidance preferred for implant retained dentures when implants are placed in the anterior? Or is it better to revert to the chew cycle and give clearance to avoid contact altogether with the anterior teeth?
Yes, the last one, the last part. Yes. Okay. Let me switch and go back. Great question. Again, this is really controversial on me, so I apologize. I'm not so much worried about the incisal table and canine guidance. No, I am more worried about how those teeth function within that chew cycle. Implant retained, non-implant retained, digital construction or non-digital, traditional, doesn't matter. What's important and what I've learned and what I have found successful for me and why I share it with you is I'm more worried about how those teeth function within that chew cycle. I don't care about the canine guidance anymore. I don't pay attention to that. I pay attention to the chew cycle and how they're functioning within that patient's chew cycle, which is like their thumbprint. So on say an all on 4 or an all on 6, okay, we've got our centric touching. I'm happy, but then I'm watching that chew cycle. Because remember that video I showed of the patient where I've got that overbite like this. I mean, my goodness. But you saw when she spoke, her jaw really came down and open. And as she spoke, she showed lower anterior teeth, just like normal. But when she'd close into centric, it buried in. But then when she spoke, I gave her clearance. Because remember, she didn't function so much right there as we check in the articulator. She'd come up and function here. So she's coming in on the chew cycle. So that's where I use the phonetics to help me understand her biting habits or her chewing habits, her chew cycle. So that's when I could set the teeth and make them work within that, because I knew that would come in and touch in centric, but it would open up automatically and not hit right away. Because her cycle was a little bit more, okay, vertical. So to answer that question again, I'm more concerned about the chew cycle than I am about canine guidance. Absolutely. You guys, I had to appreciate, I had to learn, and I use all of those learning tips and rules that we've had over our years as a base to start from. But I've thrown most of that out and don't follow that anymore. I don't use 20-degree teeth or 20-degree principles. I don't do that anymore. One of the reasons why specifically to that is 10, 20, and 30-degree style occlusion are theories from the 40s and 50s. It's not the 40s and 50s anymore, is it? This is about smartphones and technology and trends and new theories and pushing us forward. Why are we using teeth that were designed from 1950? We've moved on from that, everyone. And so that's part and parcel of what you see from me here is this, I rethink. I'm following a chew cycle. Because why? Because that's what it's doing. It doesn't matter, say, what it does here. It matters what it does here. And I have to try to modify myself to that cycle. Once you do that, success, because now I've built dentures and I show you those pictures of cases that shouldn't work, but work. Why? Because they worked for that person's thumbprint, that person's chew cycle. So to answer that question, third time, yes, chew cycle. Everything now is what I think that cycle is and functioning within it. Just the difficulty being on the lab side of things is you have to have those critical conversations with your doctors. Because again, what am I trying to do? Cut down on the adjustment rates and save time, stress, and burnout. Okay? Gosh, the pandemic has already burned a lot of us out just from dealing with the pandemic and such. So it's important that when I build teeth that I'm trying to build them for that less stress and less burnout purpose. So I really focus on how things are functioning within the mouth, within that chew cycle. Absolute. That's the takeaway from today. Okay. Address burnout, understand burnout. What is it? And then again, how am I going to manage my burnout is by setting and imagining that chew cycle and letting that tooth function within that perceived chew cycle. Now, again, I can't know everything about everything. So now I have to sometimes check it in the mouth because an articulator only does so much. So this tip you take to your doctor or you take for yourself as a direct provider. So let me just clear some stuff out of the way. Clinically, intraorally, I'm going to take a cotton swab. Pardon me. I'm going to roll it in Vaseline. I'm going to take this swab and I'm going to take the ink off articulating paper so it colors the cotton swab. I am then going to go take the denture out of the patient's mouth and I'm going to dry it. So please imagine this is a complete denture. And I'm going to go in and I'm going to color that tooth like this. So you see me color it? I'm using the ink from the articulating paper. And then that goes in the mouth. And then I'm going to do what? Have them say days of the week, months of the year in English and their mother language. And I'm going to let that thing go. And then I'm going to talk to them. Well, how are you today? Are you busy? What's up? How's the weather? Gosh, up here we talk about the Edmonton Oilers because this is a hockey city. Yes, even 80-year-old little ladies talk about the Oilers. And we talk. And then what's going to happen is then I'm going to take that out of the mouth. And then I'm going to see if there's any hits or contacts that are there, or even necessarily against the lower natural teeth. But remember, it's going to be a really light contact. So you have to watch. You're retooling your eye on this. Okay. And I'm going to go in there and I'm going to look to see if there's any markings. And that's how I check this orally in the final phase. Because again, the mouth is that's where it all functions. And so I'm trying to save myself some time by doing it in the lab. But again, sometimes you have to do that final check in the mouth. So you can take that tip to your doctor or for yourself as a denturist or prosthodontist, or if you're a doctor watching, do that check in the mouth. Never put articulating paper in someone's mouth, ever. Did he just say that? Did I just say that? I don't care whether it's thin. I don't care whether it's silk. I don't care whether it's folded and use forceps. The minute you shove something into someone's mouth, two things happen. Three things. The central nervous system going, what's that? Because I've shoved something into someone's mouth. So here's a clean Q-tip. The minute I shove something into the mouth, it's pushing against my cheek. And what did it do to my tongue? My tongue also starts to retrude. So the minute you stick articulating paper that's wide in someone's mouth, it hits the border of the tongue's instinctively going to go back out of the way. Your bite's wrong. You've manipulated the data because you've added an external influence. Don't do that. The minute you stick forceps in and you shove the cheek out, now you're asking someone to bite or tap, and you're shoving the cheek out. This is going, well, what's that? That's new pressure. I've never had that pressure before, but I'm supposed to bite normally? It doesn't work that way. You've manipulated the data. So that's why I color it with a Q-tip. And I've tried different kinds, and gosh, I've tried the sprays. This works pretty good for me because then I can get everything in their mouth, especially on an implant case. And then I let them give me the data organically to function within their chew cycle. So as you see this, as we're wrapping up slowly, you'll see that I'm trying to, again, what that first question, one of the first questions is, this is a modified lingualized occlusion on lower natural teeth. Yeah, no matter what the teeth are, no matter their shape, I'm doing a modified lingualized occlusion on it to work within a chew cycle.
Mark, I got
Paul,
a couple of questions
yeah,
here for you.
shoot.
The first one is, are you doing try-ins on acrylic bases to check the occlusion?
No, I am not. I am doing a try-in, but not on an acrylic base. I love that though. Hang on a minute. Let me reach over to my one drawer. I love that question. I use really hard wax. Got it from Candular. Okay, it's a bugger to work with because the minute you heat it, it tears. So it takes a little bit of finesse of how to do it. I use this hard wax. You can do it on an acrylic base, yes, if you want to process the base and spend that time, because again, an acrylic base or this hard wax is similar texture and roughness to what a denture base is, and roughness meaning smoothness. When you use the light cure bases, they're very rough, and so that's a different kind of sensation against the tissue. So then you're befuddling or you're confusing the central nervous system because you've put in a new texture into that person's mouth. So I use an extra hard wax. I found this. I tried the acrylic bases. So if you want to go through the process of doing that, or you can print them, but again, it has to be, the kicker here is that it has to be smooth like the final product or like their existing denture. So you try to keep the same sensations going on for them so that I'm not putting something rough in their mouth. That was a great question. So, you know, the answer is I've done it, but I've just gone to now the hard wax, and that works well for me. But when I do a try-in, my upper model's already post-stamped, everything like their existing denture was and what a denture should feel like for them. So I contour it, I've got a post-stamp in it, all those things, because I'm trying to not befuddle or influence the central nervous system as much as possible. At year 34 of my career, I immensely respect our central nervous system and how it operates and denture integration into the body and what that feels like for a patient. Paul, next question.
Next question. Do you have a strategy for protrusive contact in the anterior when the chew cycle allows for a lot of overlap and or overjet? I believe in the past you have talked about contact of lower incisal edges contacting upper incisor area. Could you elaborate?
Okay. Well, welcome back to the course again. Hey, how awesome is that? You came back. So typically we're taught in school that protrusive should go end to end, and that should be our protrusive contact. So when they bite into the sandwich, it hits and then cuts the sandwich. So you are asking a denture patient that cannot feel, especially the upper denture, and maybe they've got crowns on the bottom, but we've got certainly a big degradation of feeling, which means they can't feel. So you think that they're going to be able to move their jaw forward and know where end-to-end contact is without looking at it, and they're going to be able to feel end-to-end contact. A patient can't feel that. The only people that I know that do that are seamstresses that I've had to really customize because they want to bite the thread. So then they've learned though to move their jaw forward and posture, and then I can go end to end and so that they can touch the thread. Otherwise, because that's a learned technique, a learned movement of their mandible. Otherwise, yes, you've heard me say, I don't try to posture end to end. How this works in the mouth, when you have this position in the chew cycle, as the question stated, typically you'll have the lower come up and rest and bite here. So it's not going end to end as it's coming forward here on the chew cycle to then grab the ham out of the ham and cheese sandwich so that you bite through things. So the other controversial comment and topic that I'm going to state that was elaborated in that question is I don't seek end-to-end contact anymore, because I find it impossible for a patient to touch together and find end-to-end contact on their own. When they're functioning and they're going in that chew cycle, okay, what they're going to do is they're going to come forward, and then the lower anterior touches the lingual of the upper anterior, and that's where the touch is. So specifically, I want you to think back to that video of the lady that I built this for, and everything was touched in. She wears that sucker without adhesive. Now, how is that possible? Well, that's possible because I built that denture to function within her chew cycle. So a lot of the standard thought processes of how we build that denture, I threw out the window because I built it for her and her system and her cycle. So when she bites into something, she's moving it forward and she's coming and she's touching on the lingual aspect of the anterior. So she's let me just flip the camera. She's trying to touch. Oops. Let's do that. Oh, come on now, stay. Making me dizzy. Okay, she's trying to touch here. So it's not so much end to end that she's looking for, is she's touching right there in about the middle of the tooth. And that seems to be, from my observations, where people are trying to find that contact. So I've gone and I've built dentures for patients, and then I've asked them to bring in foods and sandwiches, and I've watched them try to function with it and watch them try to bite into the sandwich. And again, that's where my comment comes from. They're not trying to go end to end, as their jaw just postures forward and the lower touches, and that's enough quick touch that it helps cut through the bread and such. So I'm not looking end to end, as I'm more looking here in that aspect of the tooth. So if I hold it up for you, I'm looking right in there. That's where I want that contact of the lower anterior. So I hope that answers your question. You know, I apologize because of the limitations of video technology and such versus live in person. So please watch the 2022 calendar on VITA. We do have some hands-on stuff coming. So long as we're able to travel and we can do this, and I can cross the border and especially come into the States, I'd love to see you guys and again share and grow. Paul, any other questions, or does that answer that question, or is there a further comment?
No, that looks like you answered it. Thank you very much, Mark.
Okay. That's like, again, I need you to sort of, let me rotate back. Oh, look, I'm upside down. Oh, come on. Why is that doing that today? There we go. Because it's 20 degrees below zero outside. This is about letting go what you think you know. And that's really hard. I say about that getting out of your own way. What I've just showed you today in a couple hours is a little bit of the why, and then I try to show you the how quickly. Of again, I work within a chew cycle, and it's lingualized base. You've got the buccal cusp and the lingual of the lower that's trying to hold the food on the table, and everything's trying to function. And I've built dentures that shouldn't work, or technically shouldn't work, but I let go of what I thought I knew, and then realized, wait a minute, I've expanded my horizons. It's not that what I was doing was wrong before, it's just I didn't know any better, and now I've learned and growed and grew. And is that not what we're supposed to do as practitioners through the course of my career, dealing with patients every day? I should grow, because that's what my dad said. My dad had it right. Mark, you want to be doing it for 30 years, but you want to do it 30 years current. So you want to take that experience, but you want to use it with technology and trends and such that are moving it forward. That's why I have no time for 20, 30, 0, 10 degree or functional degree teeth. That's from the 50s, everyone. Say goodbye. This is about now rethinking how we build dentures, tooling it to a chew cycle that I've identified now through my career of again, that was a lot of our common complaints that we got from people was because of the hit and slide causing the problem. But my bite was right, and then I realized we don't chew in centric. So then I went, well, wait a minute. And then I started to realize, well, wait a minute, there's a chew cycle. So it's hitting and then slides into position. And that's what was causing the issues. And that was causing the chips and the breaks and the torque and the ill fit and the sore spots. And now I can consistently drop my adjustment rate down. So what are the takeaways from today as we're slowly wrapping up? It's a form of lingualized occlusion. I'm making sure that the buccal overlaps, the buccal upper overlaps the buccal lower. It's not knuckle tight. So the idea is to keep the food on the bottom teeth to bring up to get crushed. And then it's following a chew cycle of a patient. So I'm not so much worried about condylar angles anymore and such. I can manipulate an articulator now better to go in and try to mimic that chew cycle that I've tried to identify now by just simply watching someone. And I challenge you now to say when you go home tonight, watch the television or watch your loved ones at home when they're eating and watch them chew and watch them speak and start to retrain your eye. And then you have to have those critical conversations as a dental technician to your key doctors that you can have those conversations with and let them know that you're trying something different because you want to create more efficiencies and you're trying to grow and be better and be that superhero, and that you want to track their adjustments and help drop them, because we can and we do drop adjustments by following now the freedom and centric, that you don't lock the bite in and that you follow to a chew cycle. So that was my concern, was to address some of our mental health issues that we face in this profession, and specifically commonly related to dentures. And again, how to manage that to again control our burnout specifically related to the denture concerns that we face, because this is just from the perspective from the dentures. So thanks for hearing me out. Again, I'm challenging you of what you think you know and what you think you believe, and then here's this crazy Mark saying he's doing all these things that shouldn't work, and that's how I've developed it here, and it does work, and it works for me, and then that's why I go out and I share it. Paul, any other questions?
One more. Do
Yeah.
you do a pre-centric check record at the fit appointment if there's a slide?
Yes. Can you say the question again?
Do you do a pre-centric check record at the fit appointment if there is a slide?
Yeah. Okay. So that's a good question. Yes. So the answer to that question is yes, I have done it. It's not on every case, of course, especially if I know that things are sloppy. So for, let's say, from the old dentures really worn down, and I know that they have a sloppy bite, because again, I remember I've watched them during the consult. I'm watching their mandible and how they speak during the consult. And then I'm watching them when I ask them just to, hey, why don't you just try to touch your teeth together? And why don't you swallow? So one of the key points that I do is, instead of using the word bite or the word close or the word touch, I use the word swallow. And so swallowing is a subconscious command, which then the patient finds their habitual centric and physiological centric every time. So when I notice then that there's a slide because things have loosened up and the denture's worn down and it's like the alignment goes out on your car, I'm verifying that. But now to take a check bite, I'll always use the word swallow. And then that helps center the patient back in, because when you swallow, you automatically bring your teeth up to touch. They hold in centric. That provides the base for the muscles to go in and facilitate the swallowing process. So it's really hard to swallow without touching your teeth together. I challenge you to try and do it, because I just swallowed. Your teeth have to come to brace. Try to swallow without bracing your teeth or touching your tongue against the roof of your mouth. It's really hard because those muscles need that brace. So to answer that question, yes, I've done it. Yes, I've tried to take a check, as you will, but I've also changed the words, the command words that I use to the patient. So I use the word swallow, and then swallow, don't open. So now specifically, I just want to tag into the dental technicians that are paying attention and watching. If you have a doctor that consistently has poor bite record technique, or you find that the bites are always protrusive for that doctor, boy, do I need to see you on a private course. So VITA can set up a private course with you and I, and we can invite your doctors out for a wine and cheese kind of thing. But tell them to stop using the word bite or close. You want to use the word swallow, don't open. You don't want to swallow the material, of course, but you want to say swallow, because then that always finds the habitual centric. So use the word swallow, because then that's bringing their jaw back to their physiologic centric. The other thing is how you make a wax rim when you're doing a bite record technique. So that's the other big one is I'd have to show you through another course about how to redesign your bite rims. Because again, you pop something in someone's mouth and it's a different sensation, and then you're using the word bite. So you got to think about this. How many times when you live your life every day, and I'm living, no one tells me to close or bite, do they? Yet I go to the dentist's office and now here's the word bite. Well, I don't hear that word every day, and I don't certainly tell myself to bite. Yet here now I have a professional doctor telling me, hey, bite. Okay, and how do I bite? Like, it's not something you think about all the time. But when you do a subconscious command and you say swallow, well, I know how to do that because I swallow all the time. So then you follow where I'm going with those command words. You want to stop trying to trick the central nervous system by giving you the wrong information. And again, that's the running joke now that I'm in front of a camera, is we put wax rims in someone's mouth and we say bite, and you say bite, bite, and they're like, no, bite on your back teeth, and then they do that. It's like, get them to stop thinking. Use the word swallow. Okay, Paul, any other questions?
No, I think that pretty much wraps it up.
Cool. Well, I already kind of did my closing arguments, as I say, and I really appreciate everybody's time. We don't slap teeth together, and we have a very difficult job that we're trying to build something for a patient, and they again can't feel it. So we again, don't lose sight of that. That again, it's difficult what we do. We don't slap teeth together. Remember the chew cycle. Remember to identify burnout for yourself, and then some of how we can start to manage that. Paul will put up at the end, when he assumes back control of the PowerPoint here. I believe there's a picture of my contact information, Paul, on my business card. And so I encourage everybody to please send me an email. And again, I have people email me and send me pictures and videos. Like, again, look, we're here to support each other and grow and be that superhero for that patient. So, I wish everyone well, and hopefully can see you in 2022. Keep an eye out on the VITA lecture courses, please. And then contact VITA if you would like to see a course or a course specific in your area. If we can get enough people together, then absolutely. So VITA doesn't know that if you don't say anything and you're silent. So I also ask respectfully that you please contact VITA. And again, Paul and Jim's information was up already on the screen to let them know, hey, I would like a course, or can we do something in my area if we get enough people? That helps, because then that makes it worthwhile. So we can do that, because they don't know if you don't say anything. So this is about supporting you. Myself and Paul and Jim, we're here to support you. And I thank VITA for their support of me to deliver my message, and for Paul for helping out today. So thank you for that. We're here to support you in your endeavorments to support your doctor and your patient, or your patient directly. So thank you. Paul.
Thanks so much, Mark.
You can assume control, and I'm going to switch out cameras here. And you can hopefully pop up my my contact information.
So yeah, so thank you everybody for joining us today. Yes, please, check back on our website under courses, and we will have our 2022 calendar. Mark has done a lot of stuff this year, and we'll do a lot of stuff more next year. Lots of different workshops, digital and traditional, and all kinds of different topics. And like Mark said, if there's a topic you don't see that you would like, please let us know. We're always happy to help with that.
And we'll be in Chicago, hopefully.
That's right. Yes.
So
we'll be in Chicago in February, so please come by and see us.
Yes, I'll be at the VITA booth there. So absolutely, you guys, please, if you can make it to the Chicago Midwinter meeting, yes, come. That's my information. Thanks, Paul. So please contact me. You can text me or email me. Just please give me a couple days to respond. Sometimes I get a little bit busy, so I do appreciate your patience, but I will get back to you. I'm also on Facebook and Instagram and such and so forth. So look me up.
All right, terrific. Thanks, you guys. Yeah, so if you need to get
All
a hold of Mark, here is his information. If you guys have questions about product, here is the contact info for your local sales reps. So they'll have information on, pricing and that kind of stuff. If you have technical questions, please feel free to call the help desk or get a hold of myself or Jim, and we will be happy to help any way we can. So again, thank you so much for joining us today.
Thanks, everybody.
And we look forward to seeing you again soon.
Take care. Everybody gets a woot woot.
All right.
Be that superhero. Thanks, everybody.